Pretty jam-packed evening. We've already enjoyed the hors d'oeuvres, I hope, from Alastair from Simon's Gourmet Gallery. And I don't know if you recognise, but the food that we've put on offer tonight is specifically low insulinemic food because as a nutritional speaker as well, I promote a diet that helps our patients' metabolism. There's also emerging evidence that this is very important in terms of patients' spine health as well. We're starting to realise that going hand in hand with insulin resistance is leptin resistance, and leptin is a hormone that's actually being identified as toxic to cartilage cells, and in all of our joints, including our spinal discs, we have chondrocytes. So not only am I trying to help patients' metabolism, their chronic inflammation and their spinal conditions, we also need to think about their nutritional resourcing too. So I work very closely with a dietitian, and Alastair from Simon's Gourmet Gallery has prepared all of our beautiful food tonight, and you'll see we've got a self-serve dinner later on in the evening for you to enjoy while we listen to Dr. Mark Craig, who you may have heard of, a musculoskeletal physician, also known as the back doctor, and please enjoy your meals while we watch an interview that I've conducted with him. Sadly, he's not able to be here tonight in person, but we're going to talk to him anyway, virtually. And then we've got Ms. Rachel Robinson, who's a physiotherapist that works very closely with us, and how her physiotherapy practice has been really transformed by our NeuroHAB movement therapy program. And throughout the evening you'll start to appreciate the distinctive and unique differences between physiotherapy, physical therapy and movement therapy. Okay, I really want to emphasize that movement therapy and physiotherapy are two very different things. It's like a helicopter pilot and a jumbo jet pilot. If you're going in a jumbo jet, you don't want a helicopter pilot at the wheel. And likewise with our all forms of physical therapy, there are distinctive differences. And in general, movement therapy is fairly uncommonly available to you. So I'm hoping that tonight is really going to be enlightening for you and give you a few light bulb moments in regard to a very common problem of low back pain. And I've been mingling with the crowd tonight, and I think every doctor that I've talked to tonight has expressed that they see many patients with low back pain, and there's a common theme that everyone's saying to me, and it's what do I think of this treatment or this prolotherapy or acupuncture or massage, and I can tell from those comments that you're all in the same boat with not really thinking about the cause of back pain, and that's really on a global scale the major problem with back pain management today. And I was fortunate to work closely in multidisciplinary teams with musculoskeletal physicians, pain specialists, physiotherapists, and that taught me a lot about what works for back pain, but more importantly, it taught me what didn't work. And I really started to feel that there were more people that we weren't helping than that we were helping. And it really made me start to think, what are we doing wrong here? And that's what led to the evolution of this centre here, called the Functional Movement Training Centre, which of course is a collaboration of my neurosurgery practice, City to Coast Neurosurgery, and together with our fantastic team of movement therapists, nutritionists. We've got all of our accessory physical therapists on tap. We've got pain specialists on tap. We've got psychiatrists on tap. The collaboration of all that expertise to develop this Queensland Back Pain Centre of Excellence, and I really am appreciative of St Andrew's Hospital to see my vision for developing a centre of excellence right here in the city and Dr. Yogesh here is one of the administrators of the hospital. So just a quick plug to Yogesh to say thank you very much for letting us develop this centre here, and it's going to do wonderful things. And even in the short time that we've been here, we've been really delighted with how patients are responding and appreciating the service. So let's move on and have a little think for a moment. Just imagine you're a patient now, and you've had pain for 5 odd years. You had a minor injury at work, and over time this pain relapsed and remitted, but it never really went away. You kept working for a little while, but soon it started to really interfere with your quality of life. You started having to take more and more analgesics. You struggled to work after a couple of years of feeling this constant pain. Of course, you suffer socially and financially. Your family interactions are compromised. I always hear stories from patients and it's really heart-wrenching. You know, I can't kick a footy with my boy. I can't go for a surf with my boy. Can't go to the beach. All these things that we take for granted when we're pain-free. This, of course, affects our mental health, our general health. You do the natural things. You go to your GP. You go to a myriad of corner store physical therapists, and there's many out there. And you spend hours and a lot of dollars on these passive types of therapy. You know, you do feel tight in the back, so of course you need to get that. You feel like you need to get that muscle released. Everyone tells you, because you're continuing to fail, you've got persisting pain, that it's because of your worn out discs. It's because you had a heavy work history. You've got a lot of degeneration there. So you're probably going to need a fusion or a disc replacement. You know, all this work that I'm doing on you is just not helping. So you're probably going to need to have surgery. And like any sensible person, you go and get a couple of opinions from surgeons, and you get a bit of a mixed bag of opinions. And some say don't ever have surgery. Some say yep, surgery will fix you. Sign here, and you eventually have your surgery. Sadly, it fails, as it does in over 50% of back surgeries. Over 50%. And then, because I run a pain surgery practice and a multidisciplinary team, and I specialise in movement therapy, you finally see me, because it's not the first port of call going and seeing a movement therapist specialist. Okay. I happen to be a neurosurgeon, and I do lots of spine surgery too, but I'll explain when and where the place is for surgery. Okay? I'm in surgery 2 days a week, but I have a very specific algorithm of when and why I operate on people. Now, I ask you this: what disease have you suffered from when you come and see me after 5 years? And I ask every patient that question who has persistent pain. I said, you've got this terrible pain. What is the disease? You've seen numerous therapists. You've seen numerous doctors over a period of 5 years. What's the disease that you have? Do you know that not one person has told me what disease they have? They just tell me that they've got back pain, or they've got worn out discs, or they've got a bad back, or I've got weak core. And that is not a disease, okay? These are all symptoms of a disease. And then I have to say to them, how could you possibly recover from symptoms without a recognised disease? I tell you that you're still in pain because your disease is untreated. You probably didn't need the surgery. All the rehab that you've had done was doomed to failure, and actually probably made you worse through the effects of central sensitization. That's what happens when someone's rubbing your back 3 times a week for half an hour. You start to do funny things to the brain, and that's called centralization. Active exercises and core strengthening in isolation is not harmful for you, but it's not going to ever fix your back pain. The disease that you suffer from is movement dysfunction, and then you look at me a bit puzzled. You say, what do you mean movement dysfunction? And you have failed rehab syndrome. You've had 5 years of rehab and it hasn't worked. Has anyone heard of the term failed rehab syndrome? No, but it's real. they have failed rehab syndrome. And then they've got this second disease called centralisation. It's now an extremely challenging problem. Not insurmountable, but it's very challenging. You've been let down by the back pain therapy industry. And if you'd seen me after the first, second episode of back pain, or within 3 to 6 months, we could have fixed you within 8 weeks and got you onto the right path for your body to mend itself, because we target the cause. So this next short video drives my passion to continue taking time every day with our patients, explaining to them what needs to be done to train them to help themselves, to allow their body to fix themselves up. And sometimes I'm confronted by disbelief. Sometimes I'm confronted by anger and frustration. So it's a very fine line, the way that we need to get patients to understand what's wrong, because there's so many misguided concepts that are entrenched over years and years of suffering back pain. But have a look at this video and it'll give you a little bit of an idea of what we can do for patients.
All of our patients have a journey and a story, and it's really easy to underestimate the impact chronic pain has on their daily lives.
I was only able to stand for probably about 5 minutes without my pain going through the roof. It was like having a torch just burning right along there, so 24/7.
I think the other thing that I always found very difficult was walking. I get to sort of 100 metres, so I go shopping, I go 100 metres and I'd sort of be all crunched up.
Being in a gym is daunting to a lot of people who are in chronic pain, who have been told to rest, not to lift things over 5 kilos. Then suddenly they're walking into a gym and you can see there's kettlebells, there's wall balls, there's barbells.
My first day I came in and it was like, okay, you've got to stand up straight. And I think, I don't think I can. And so, they basically talked me through how to stand and how to position myself and stand up straight.
From day one, we learnt to how to stand properly. I can go to the shops now. I did have a disability parking permit. I no longer have that disability parking permit.
It's made a huge difference in terms of my mobility and the pain threshold. So, yeah, and I think that helps your confidence and how you feel about yourself as well.
And looking at what happens at home, general movement around the house and the ability to function in a more normal way, I guess we put it, it's improved her quality of life.
It's a place of health. It's a place where they get to do things, and all of these things they've been scared of, they can actually gain confidence in and realise how much they're capable of.
So it's very satisfying to see patients like this who are really biased towards failure right from the outset do so well, and for them to come and see us and think that there's no further hope, and then to recover so incredibly and regain their functional capacity. You can see how it drives our passion here. So there's been lots of literature about the spine pain industry. Now, do I really think that it's a hoax? No, I don't think it's a hoax in the true sense of that word. I think all of the physical therapists and doctors that are looking after back pain, they want their patients to get better, but unfortunately, there's just too much muddied waters in terms of what we need to do to actually really make a difference to our back pain patients, and I include myself in that category. Up until 5 or 6 years ago, as a specialist neurosurgeon, I hadn't put the puzzle pieces together. Okay, and that's why I really refer to it as the back pain puzzle. We all have little islands of knowledge that represent the jigsaw puzzle. But most of the people treating back pain have not put those puzzle pieces together to see a really crystal clear picture of what needs to be done to address this very, very common condition that we're all seeing every day. But I can guarantee you that treating symptoms like this with a hot water bottle that eventually gives him first-degree burns is never going to treat the cause of back pain. This is like the extreme of treating symptoms, okay? And so what's drawn me to these conclusions over the years? Okay, it's just that every single day I'm faced with correspondence like this, and if you receive correspondence like this every day, you'd be mad to not think that we're doing something wrong, okay? So here's a triathlete, and he's seeing his physiotherapist, and he's got back pain. So he's fit, he's got a strong core, and the physiotherapist's mode of treating him is to strengthen his core even further. That just doesn't quite make sense to me. Here's a surgeon who's done an operation on Chris, and overall he's very happy with the progress and the outcome of surgery, but he's told his patient that he just shouldn't bend because that causes back pain. How can you be happy with that? Here's a patient who's been referred to me, and he's had the full house, the first three, physiotherapy, Pilates and core strength. That's our knee-jerk response for back pain. But he's still continuing to have severe low back pain. It's impacting on his sleep and, of course, every other facet of his life. Medico-legal and insurance reports, okay? I see this all the time, where the specialist, the back pain specialist, is saying this person's pain is due to lumbar degeneration and they need to go back to work. Degeneration is normal, okay? So obviously whatever's causing their pain hasn't been addressed, and if whatever's causing their pain hasn't been addressed and they go back to work, what do you think is going to happen to their pain? They're going to fail. So they'll go back to work for a return to work program, and of course the moment the functional demands slightly increase, they're back off work again. This happens time and time again. Another physiotherapist writing to me, same sort of story. I'm doing physiotherapy, but it's not helping his function. And here's a physiotherapist that's written to me himself, saying that I'm disillusioned with conventional physiotherapy for back pain. What are you guys doing at the Functional Movement Training Centre? Okay, and now he's one of our therapists delivering functional movement therapy in our satellite centre in Toowoomba now, because he was honest that what he was doing was not actually tackling the problem, and now he's completely transformed his practice. I look at the literature, of course, and here we have The Lancet, one of the most prestigious medical journals in the world, talking about our run-of-the-mill low back pain. This is what they call it, non-specific low back pain. And just even the term non-specific low back pain is a little bit like switching the brain off and saying, I don't really know what causes it, so I'll just call it non-specific. You're already doomed to failure if you have that attitude. And the abstract says, well, yes, the occasional rare cause of back pain, like ankylosing spondylitis or spondylodiscitis or infection or tumour, yeah, we need to identify what causes that. But for the millions of patients that have just the run-of-the-mill back pain that costs us billions, don't worry about that, because non-specific low back pain has no known cause, has no pathoanatomical cause. So let's just keep treating the symptoms. It doesn't make sense. And these are the pieces of the jigsaw that just didn't fit for me until about 5 or 6 years ago, when I developed movement therapy centres. We've all heard of the Cochrane database, okay? It's a unbiased, objective review of global literature on topics. And if you actually take the time to look up Cochrane on all of these therapies, that I'm sure you have referred patients or seen patients who have described having them. And one of the doctors asked me about acupuncture, massage, prolotherapy. A doctor asked me about prolotherapy tonight already. Motor control and exercise therapy are the most common causes, the most common treatments that people go to first line for their back pain. And guess what? Pilates, adjustments. Cochrane does not support any of them for medium or long-term resolution of back pain. Okay? There's so much misleading information in the in social media as well. So blaming genetics, blaming body weight, blaming weakness or tight muscles for back pain is just unhelpful. And in fact, we should really have these arrows going the other way round. It's not the tight muscles that cause back pain, it's the back pain that causes the tight muscles. All right? And yet we're quite happy to stand up and publicise these illogical philosophies on why people suffer from back pain. The back pain treatment studio economically is really just not set up. It's not economically set up to manage back pain effectively. But yet this is what pretty much every physiotherapy or physical therapy studio looks like now. And it really is anti-movement and it's anti-skill. And with anti-skill and anti-movement, we're not going to succeed at looking after back pain. The moment you send a patient to a physical therapist who lays you down on a couch, you're already failed. Okay, this is anti-skill. Every patient that comes to the Functional Movement Training Centre leaves with a new skill, and that's critically important. We are transferring a skill to our patients. And as you probably gathered when you walked in here, there's not a single couch. There's not a single couch in this centre. I call them the killer couches. So what do I do every day? I observe people moving. I understand movement. I understand the points of performance that are critical in proficient movement. And I look at their MRI scans. And it's very, very easy to say, oh, well, you got back pain because the MRI looks a little bit degenerate. But that, of course, is completely misleading. And the MRI scan is actually the least important factor that determines whether someone has back pain or not. If that were true, then we all better get ready for terrible, agonising facial pain, because we all degenerate and all parts of our body degenerate, but degeneration does not equal pain. Okay. Is low back pain a complex problem, or is it a simple problem? And I don't know whether you've heard of the Occam's razor principle. If we have a complex problem and we keep it complex, we're going to struggle to find a complex solution, and the likelihood is poor success and efficacy. Whereas if I can break down this complex problem to a really simple root cause, I can then just address that root cause and I'm likely to have higher success. And that's what I've done with back pain. This is from Blomberg's musculoskeletal textbook, and you can see it's very complex. It's very complex the way that he describes different pain syndromes and different scenarios where you have to do different things. And even you can't see at the top of the slide, but at the top of the slide it says the pain patient. Again, a world leader in back pain is not recognising the cause. He's saying, well, you've got back pain. Let's work out how to resolve back pain, not actually think about cause. Compare this with my domino concept theory of movement dysfunction being the very first domino to fall over, and then following on from that, we have all of these other conditions. So we then get our disc prolapse, or we get some discitis, or we get our facet joint pain, and then we get our tight muscles, and then we get bursitis, and then this leads on to sacroiliac joint pain and stenosis and instability. It's so simple. It's so simple to then sort out all of these downstream phenomenon by targeting movement dysfunction as the imperative. Yes, we may need to do our, one of the doctors was asking me about epidurals. Yes, we may need to do an epidural when we've got inflamed discs or we've got inflamed facets. All of those structures are nociceptive, but the epidural is not the definitive answer. The epidural is adjunctive. This is the definitive answer, because once we stop this domino from falling over, we then don't get these secondary problems. So it's a really simple concept. And this is probably what we do every day. If someone comes to see you with back pain, okay, go and have a rest, don't go to work tomorrow. Of course, we've given them medications, prescriptions for over-the-counter and prescription medication. We've asked people to modify their lifestyle, educate people, of course, there's many types of educational approaches: cognitive behavioural therapy, meditation, graded motor imagery. I'm not quite around that concept that if we imagine it's not hurting, it's not going to hurt. That's what they're really asking us to do. Physical therapies is the next step. Okay, we're going to go and do some usual things like those correspondence letters will say. Motor control, Pilates, core stability. We might then go to a gym and we'll do all these things to try to get our physical condition healthier. And then if it's still not helping, now we're going to go and start doing some invasive things. So we're going to start burning nerves with radio frequency. We're going to start injecting our joints and epidurals, and then we're going to go and see the surgeon. That's the pathway that people follow. Can you see that none of that addresses cause? So what is the best therapist for your body? Of course, it's your own body. Okay. Now, the fellow that says I'm still in pain because of a work injury 5 years ago is really saying that he has failed to identify the obstruction to his body healing itself naturally. So if you stubbed your toe 5 years ago and it still hurt today, you wouldn't be thinking or saying to someone, I've got a sore toe because I stubbed it 5 years ago. You'd be thinking, what's happened that stopped this toe healing itself over the 5 years? That we accept that for most other conditions, except in back pain, where we continue to think that injury from 5 to 10 years ago is why I'm still in pain now. So how significant is back pain in our community? That's pretty significant. This is in the centerfold of the Australian 6 months ago. Our Bureau of Statistics say it's one of the highest economic health burdens in our society. We're talking billions of dollars, not millions, and this is old data from 2009. It's one of the most common reasons to present to the general practitioner. If you have an episode of back pain, there's a 75% chance that you're going to have another episode within 12 months. Lifetime prevalence and point prevalence are ridiculously high. And this is really concerning, that one episode of back pain has a 10% chance of lasting longer than 3 months. And 3 months is sort of that time period where you can start to develop those neurophysiological changes of centralisation, and then you're in this chronic category of patient, and it's a much bigger problem. And we know that spinal surgery and spine surgery in hospitals is big money. Would you agree with that, Yogesh? Spine surgery is a huge part of the hospital revenue. And it's increasing. The prevalence is not coming down, it's actually increasing, which is concerning. Look at this patient's record of consultations to specialists over a period of 2 years. That's like a visit once a month to a specialist. It was under an insurance injury, a very trivial injury, just bending over, getting something out from underneath the bed. She was a cleaner. Absolutely pristine MRI. She's seen a specialist every month for the last 2 years and still in pain. Think of the resource consumption that's having on our society. Now, these are my surgeries. Now, I could talk to you about these surgeries all night. I love doing these operations, Yogesh. I love doing these operations, and I do them 2 days a week. But I have a very specific reason for doing them. And talking about these surgeries to you is not going to help you understand the back pain puzzle. It's important to realise that all of these surgeries are being done to treat a symptom. Okay, I'm treating a symptom. They do not treat the disease that causes low back pain. What made the patient need that surgery in the first place has not been addressed by these operations. These are treating symptoms. So I'm really a symptom surgeon, and I then need to follow that up with treating the disease. We must adopt what I call the tandem approach. So I'll just show you a quick video here as well of that tandem approach in action. So a fellow who had a minor injury, he had persisting low back pain, just like that pattern of of statistics on back pain. You know, it was relapsing, remitting, then became persistent, because every time you have an acute episode, there's a 10% chance of it persisting. Surgeon 1 thought, yes, I've got a bit of a bulging desiccated disc at L5S1, so he had a anterior L5S1 fusion, and that's it there. Guess what? His pain persisted, because that's all he had. He just had the fusion, and his pain persisted. Again, nothing's been done for the cause. Surgeon 2 thought, oh, that looks a little bit suboptimal, so what I'm going to do is I'm going to now brace it and fuse him from the back, and this time I'm going to extend the fusion another level and integrate L4-5, because that disc is looking a little bit desiccated now too and bulgy, so I'm going to lengthen the fusion. Guess what? That didn't help either. Okay, so now he's come to see me because I look after everyone's failed back surgeries, and I've said, look, you know, I think we do need to do something because you've got such terrible pain. We've got to do something about your pain, and I cleverly put in a dorsal column neurostimulator in, and guess what? Yeah, that helped for a short period. Okay, it helped for a short period because at that time I really wasn't on the page of movement therapy. Okay, I was one of those ignorant people that just didn't quite work it out yet. And then he came back and said, listen, it's my pain's back. And I looked, x-rayed it, no changes, the machine's working. Why has it come back? Because we haven't treated the cause. And then I said, then that was about the time that I was starting to get a bit more aware of movement therapy. So I said, let's go and do some movement therapy. And this is what he's like now. Steve, I'm going to have to show this to Judith, I think, Steve. Look at that. Awesome, Steve. Now we've focused on movement points of performance. Okay, movement, and that's going to become clear to you through the night. You're going to understand, you're going to acquire the skill of movement proficiency through the night. But his pain disappeared after that. I want to talk to you and introduce you to the MOB concept, the MOB concept. MOB stands for Movement Obstructing Barrier. So true MOBs must be eliminated first before commencing movement therapy. Okay, you cannot do movement therapy in the presence of an MOB. You just can't. I'll give you an example of some MOBs. So say your nerve's compressed. Say you've got a nerve root compressed. There's no point coming here to try to do movement therapy in the presence of a compressed S1 nerve root. You just won't succeed. Of course you need to see the surgeon. Say you've got structural instability, severe spondylolisthesis or something of that nature. There's no point doing movement therapy. You've got to see the surgeon. If you've got severe pain and you're expecting our movement therapist to be able to transfer this new skill of movement proficiency to you, it's not going to work. You've got to have some pretty advanced pain management techniques to control that pain so that you can do movement therapy. So things like ketamine infusion, spinal cord neurostimulators, peripheral nerve neurostimulators. We then do those procedures. But we are only doing those procedures, the surgery, the ketamine. Very few people are so weak that they can't hold their torso up. But there are occasions, maybe 1 in 50 or 1 in 30 patients is so weak that they can't do movement therapy. And yes, we do need to do some of those motor control, Pilates, hydrotherapy strategies first so that we can then leapfrog into movement therapy. Okay, so it is a stepping stone towards doing movement therapy. But overall, it's pretty uncommon, that MOBs in general are pretty uncommon. I'm regularly surprised how people want to give movement therapy a go and succeed when I originally thought they had an MOB. So what is movement now, and why is proficiency so important? Animals, toddlers, functional athletes, for them moving well is the norm. Okay, we don't specifically teach toddler how to move. It just happens. It's in their DNA to move well. We don't look up in the sky and see a bird flapping one wing and going around in circles. It's just natural. They maintain movement proficiency throughout life. Functional athletes train every day to move well so that they can break world records. Could our modern industrialised life be our domestic cage that makes us move like this? Okay, I think it is. And we erode the elements that comprise movement. The elements being the nuts and bolts and motor of our body, the tendons, ligaments, joints, and our muscles. And of course, the steering wheel, the master controller, the central nervous system, which controls all of the above. Now, conventional physiotherapy, physical therapy, adjustments, massage, that's fantastic. That is absolutely fantastic for looking after our nuts and bolts and motor. But it doesn't do anything for the central nervous system. And as you may have gathered, our program is called NeuroHAB for a specific reason. We are rehabilitating the nervous system. The nervous system is the steering wheel. It's the controller of movement. And I actually think that we can go as far as calling back pain a central nervous system movement disorder, far more than we should be calling it a musculoskeletal problem. It's a central nervous system movement disorder. And if we think about back pain as a central nervous system movement disorder, we now have a light bulb to what do we need to do to cure that disorder. We need to fix the movement disorder. Why is proficiency so important? Well, if we move poorly for a long time, it's like high fire danger season, okay? High fire danger season. Because movement dysfunction increases the substrate of degeneration in our spine. And it's well shown in literature that people who have back pain, in general, they have more degenerative changes in their spine. And we can see that on MRI, and there's lots of association studies. The wrong conclusions are drawn, however. The conclusion that's drawn is that degeneration then causes the back pain. But that's purely an association. It's the movement dysfunction that causes the back pain, which is associated with increased degeneration. Okay, so high fire danger season, if you've got a lot of dry grass, it doesn't take much more than a little spark to transfer that, to convert that into a raging fire. Okay. So movement dysfunction compromises functional capacity. It's a bit like going for a bushwalk with a stone in your shoe. You're not going to be very functional with that stone in your shoe because you're not moving properly while that stone's there. And the other thing is that movement dysfunction promotes more movement dysfunction over time. It's a bit like weeds in your garden, right? And the problem with that is that when we have this imbalance or this mismatch in the seesaw where our functional capacity falls below functional demand, that's when you expose yourself to the risk of pain. So we can get people who are moving poorly and they go, I don't have back pain, I got no back pain. But that's because their functional demand is below their capacity, or they're just modifying their lifestyle to keep their demand very low. But for a worker who's got to lift this 5 days a week for the next 20 years, as he moves poorly, his functional capacity slowly declines and his demand stays the same, and now the seesaw is tipped in the other direction, and he then exposes himself to the risk of injury. And you can see this is a dysfunctional movement. 2 years later, it's even more dysfunctional because movement dysfunction promotes more movement dysfunction. And this is a very simplistic slide to explain to patients that movement dysfunction is like driving your car with a flat tire. And then when you go and see someone who's a bit misguided, who gives you pain medication and core strengthening and stretching, it's like putting oil in the car, a bad mechanic putting oil in your car when you've rolled in like this. In isolation, there's nothing wrong with that oil. Okay, you can't argue, there's nothing wrong with putting oil in the car, but really what you needed was your tyre pumped up. That's what's going to get your vehicle moving properly. That's what's going to get your body moving properly. And pumping your tyre up is like implementing NeuroHAB or treating the cause. So what does movement dysfunction look like? I'll just play this video. 2 patients. 6 months of physio, 1.5 years of physio. This is her first consult with me, and this is how she moved after 6 months of physiotherapy 2 or 3 times a week. That's Anna's best attempt after 20 physiotherapy sessions. And this is her after 6 weeks of movement therapy. 6 weeks. And her second consult. And she wants to go back to work at this point. Okay? And that's after 20 physiotherapy sessions. Our second patient here. Thanks, Anna. We've got a lot of work to do. Very similar motor patterns, very similar corrupted motor patterns. 1.5 years of those nuts and bolts and motor type therapy. but no central nervous system rehabilitation, no motor pattern rehabilitation. After 6 weeks of that, he's moving like a champion and pain-free. So if we accept that, that movement dysfunction is the disease that triggers a host of downstream symptoms, like that domino effect slide, then we must have a very tight and clear definition of the points of performance and the skills that we're trying to transfer to our patients. And this is what we synthesize all the science down to. Okay, these are the points of performance that we are making default movement patterns for our patients, so they don't even think about it. Like driving a manual car, you don't think about changing gears after your first, 6 months of driving lessons. You just change gears without thinking. And our patients acquire these skills fairly quickly. When I say quickly, over about 8 weeks, and our program is 8 weeks. The 5 points of performance are hip-centric rotation, neutral spine awareness and maintenance in the loaded positions, posterior chain activation, posterior kinetic chain activation. You'll understand what that means shortly. Unloaded knee position and a satisfactory range of motion to do their activities of daily living. And if we strive to achieve these 5 points of performance, we know that strength, work capacity, mobility, flexibility and power will all naturally follow. And this is what our patients look like. Again, no couches. Okay, our prime focus is on movement proficiency. It may look like that this is an exercise program, and it may look like we're trying to make people stronger, but we're not. We're actually focusing directly on their brain and spinal cord. It's a coordination program that's teaching people to move properly, and when they move properly, they can do pretty incredible things. And even better, their pain disappears. I'm going to play this slide to highlight virtuosity of movement and the link to degeneration. This is a lady who was a veterinarian, and she was convinced, she'd been told by numerous people that she needed to have surgery. And I looked at her MRI and said, holy mackerel, that looks like an operation. I looked at my calendar and sort of started thinking when I could fit her in for a fusion. But she didn't want to have the fusion. She wanted one more try. Someone had told her about movement therapy, and here she is doing movement therapy. Stay nice and tall, Carol. Nice and tall, keep the back straight. Pretend you got the broomstick behind your back still. That's good, Carol. Very nice position. Fantastic, Carol. Really good. So I repeat her MRI. Guess what? What do you think the MRI looks like when I repeat it after the program? It's identical, but her functional capacity is through the roof and her pain is gone. There's no way she's going to think about having surgery. Just doesn't need it. So what else have we done over the last 5 years? We've actually done some movement analysis, and I'll play this slide very quickly because we're trying to keep... So this is using EMG and magnetometers and accelerometers. And you can see the traces there, the black, blue, red and purple and green. And we apply this to our patients at the beginning of the program and at the end of the program. So this is corrupted movement trace patterns, particularly this black line here. Not a lot of difference in the EMG, but if you have a look at normal movement patterns and abnormal movement patterns, black line down here, you'll be able to appreciate that that there is a significant difference in the way the body's moving when you're subjected to that electrical analysis. As movement therapists, we don't really need that electrical analysis. We can see it and we can observe people just with our eyes because we've got the skill to do it. But that just adds a little bit of extra science behind the concept. Now, I also went to a workplace and just looked at people's movement and graded what is the prevalence of movement dysfunction. And just gave them that simple task. And after doing that, about 9 out of 10 people fail that simple movement proficiency task. 9 out of 10 people fail those points of performance that we're striving for. And guess what that matches? That matches our lifetime prevalence. Even though they weren't necessarily having pain at that time, that just means that their potential to decline their functional capacity below functional demand is there. And it will happen if they maintain movement dysfunction. Of course, we assessed our ODIs, okay? We assess our ODIs in everyone. This is the gold standard for back pain and function, Oswestry Disability Index. We make all of our patients complete this survey. And on average, remember I said earlier that our patients are biased towards failure? On average, our patients are sitting at 30%. That's very high for a presenting level of back pain. Most studies will assess patients who are sitting around 15. So our patients are actually like the worst of the worst, and we've dropped their ODI scores by half at the end of the program. A very quick slide or two on central sensitization, because someone asked me a little bit about that. We have to do the very best we can to stop our patients falling into this really disastrous state where our nervous system actually undergoes neuropathophysiological changes in the neuronal connections, in the neurotransmitters that converts normal, healthy, adaptive pain into maladaptive pain. Pain is very helpful for us. Pain is how we learn. Pain is what protects us. It teaches us if we touch that, it's hot. If we touch that, it's sharp. That's called adaptive, helpful pain. But when pain becomes obstructive to the healing, we refer to that as maladaptive. And once someone develops these problems in their brain and they develop things like hyperalgesia or allodynia, where just touching them on the back or going over a speed bump causes them to grimace in pain, then that is counterproductive to them healing. The pain is now not helping that person, it's actually making that person worse. And that happens after about 3 to 6 months of feeling constant pain. And I have to explain this to patients and take the time to explain this, that it's like the nervous system is this big jumbled up ball of string of tangles. And in the presence of movement dysfunction, we can never start to unravel those tangled up threads. But if we start to train people who have centralized pain how to move properly, that's the beginning. Tangle by tangle, the nervous system can break down those neuronal interactions that constitute central sensitization. And the very first video I showed you of that gentleman who said he had searing red hot pain in his back and had a disability parking permit. He was a clear example of someone who's got central sensitization terrible. In the beginning, he could only handle about 5 minutes of movement therapy. He would then sit out of the class for the next 35 minutes. But as time went on, he became more and more proficient, and his central sensitization has weaned right off, and you can see what he's capable of now. So, final slide, just to summarise the talk. Spine pain is a huge and increasing economic burden. It's generally and globally managed poorly. Back pain and neck pain or spine pain is not a diagnosis. It's not a diagnosis. Movement dysfunction is the disease that causes the pain. Normal pain-free degeneration transforms into painful degeneritis under the influence of movement dysfunction. Degeneritis is not normal. The imperative is a tandem approach, managing the cause in conjunction with the symptoms and eliminating the movement obstructing barriers. Okay, so I'm a movement obstructing barrier surgeon. I do my surgery to eliminate movement obstructing barriers so that they can engage in movement therapy. That's the algorithm. That's why I do surgery. The software or the central nervous system motor pattern fix is NeuroHAB program, and conventional physical therapies is a hardware fix and generally anti-movement, even when exercise is integrated into the program, because the exercise is not focused on the nervous system, the exercise is focused on the muscles. And remember we said that back pain is a central nervous system movement disorder, and centralization is the result of not disrupting this movement dysfunction causing more pain cycle. treating low back pain with NeuroHAB can get the worst of the worst back pain patients into the best athletes. And just one quick slide just to let you know that I am a brain surgeon as well, so if you have central nervous system problems other than spine, you can feel free to refer them to. Thanks very much.